The recent paper in the Journal of Clinical Oncology from Chris Hourigan's lab built on the important randomized trial delivered by the US bone marrow transplant CTN, which compared outcomes in adults with AML in CR1 or myelodysplasia who had a transplant using either a myeloablative or a reduced intensity conditioning regimen. And what Hourigan's lab was able to do for the first time ever was to assess prospectively the role of MRD in trying to ascertain which patients might benefit from a myeloablative or a reduced intensity regimen. The results of the study itself showed rather controversially that because the trial was plausibly stopped early, that there was some improved disease-free survival in patients who received a myeloablative regimen rather than a RIC regimen. But the question, of course, arises which patients might benefit particularly from a MAC regimen and which patients could get away with a reduced intensity regimen, given the fact that they demonstrated significant reduction in transplant toxicities you might expect with a reduced intensity regimen. And what Hourigan was able to show, firstly, was that MRD assessed using next generation sequencing, so not typical flow MRD or PCR based, but a very sophisticated NGS technology, firstly was predictive of disease relapse, but particularly importantly, that patients with MRD positivity did much better with a myeloablative regimen with a reduced intensity regimen. But interestingly, patients who are MRD negative, the outcomes appeared to be equivalent, regardless of whether you used a reduced intensity or a myeloablative regimen. So this study is important, is novel, and the data are potentially practice informing. It's important to note some caveats. The form of MRD that was used is not one that is routinely available. We're still waiting for studies using flow MRD. The study, of course, did have some rather discrepant findings in the clinical rates of relapse that were noticed with the reduced intensity in the myeloablative regimen. The relapse rate with their chosen myeloablative regimens was somewhat lower than we might expect, and the relapse rate with the RIC was a bit higher. So I think it's going to be really important that these studies are replicated. But what it does appear to say is that at the moment, in patients who are MRD positive, there is a good case for adopting a myeloablative regimen, whereas in older patients, particularly who have MRD negativity pre-transplant, that one can probably manage with a reduced intensity regimen. The challenge, of course, is what you do in older patients who aren't fit enough for a myeloablative regimen or MRD positive. And there, I think that's going to highlight the importance potentially of post-transplant strategies such as maintenance therapies to improve their outcomes. And then finally, I think the other really important aspect of this pivotal paper was the emphasis that the transplant community really must get its act together to rapidly deliver prospective randomized trials of conditioning regimens in particular diseases with embedded MRD and genomics, if we're going to serve our patients and more precisely understand how to improve transplant outcomes.